as well. We're just waiting on Dr. Shibu John to start. Oh, hi, Danielle from Copper 3D. Great to see you here. I'm waiting to hear your talk too. I think it's going to be great.
Hi, Philip.
Hello.
Good to see you, to connect with you, Philip. And I have got to know that you've been doing some great work in the space, and it's an opportunity to connect. And I'm sure the presentation would be interesting. So right now we are live. I thought we are actually backstage, and then we would have come. But nevertheless, we will start the session. We will reason because we will also want to record. Yeah. So we will not wait for much time. We will start with it. Thank you so much. Yeah.
Okay, sure. Thank you. All right. So let's go. First of all, I want to thank Dr. Shibu John for the invitation and the opportunity to be able to share my work with you. I think it's really important to have these kind of spaces where we can, interact with other people. My name is Felipe Suntaxi. I'm from Ecuador, and I'm going to be talking about virtual surgery, my concept of virtual surgery, and patient-specific instruments. So in the topics for today, we're going to be, looking at the concept of what virtual surgery actually is. We're going to talk about patient-specific instruments, and then I'm going to talk about some case studies in orthopedic surgery, maxillofacial surgery, and cardiothoracic surgery, which I think it's the best way to, explain you what these concepts are and what I'm trying to convey to you. So first of all, what is virtual surgery? And we might have different names for it. 3D surgical planning, virtual surgical planning, preoperative planning are the most common. But all of those have the same core concept, which is, going from a CT image or any other imaging study. It can be CT, MRI, even some ultrasounds are also usable. And we're going to extract, through segmentation, a 3D model of the structures that we're interested in. And then using that 3D model, we can, perform the virtual surgery, like in this example, it's a periacetabular osteotomy. We can, perform these movements, these procedures virtually, so we can then evaluate what the outcomes will be. Whether we need to modify something in order to get the desired outcomes in a risk-free environment, like the computer. This is especially useful in, some cases such as joint replacements. We have a total shoulder replacement here, and we can see that we can plan, the size of every single component that goes into the patient's joint. And then, we can, through some simulations, evaluate maybe some scapulohumeral rhythm, and, we can see whether our surgery is going to deliver the outcome that we want. Now, why should we perform virtual surgery? And I like this saying that says, planning makes perfect. Yes. So current medical imaging technologies provide us with very valuable information about the patient-specific anatomy, pathology, and we can use this information to, create very accurate 3D visualizations, 3D representations of this patient that we can also use to create tangible models, through 3D printing. And, we can also have these 3D models to perform virtual surgery, like I just told you. And, these 3D models are also used to develop and design implants and patient-specific instruments. What you have here on the left is just an AR representation of a patient's foot. This can be, taken into the OR to have, a really cool and new and interesting visualization tool of the patient's anatomy. Now, patient-specific instrument. How do we materialize our virtual surgery? How do we transfer our plan from the virtual space in the computer to the actual OR? And the answer is through patient-specific instruments, which I'm going to refer as PSI throughout the talk. PSI allow us, to transfer our plan from the operating room, from the digital space in the computer to the operating room. These instruments, are very accurate instruments that are designed to fit exactly on a specific anatomical landmark of the patient. These landmarks are usually, bony prominences, bone especially. And these patient-specific instruments help us, to reach the precision that we plan. So these patient-specific instruments are very important because they help us to replicate the outcomes that we planned on the virtual surgery in the computer, but in the actual patient in the OR. So here's an example. It's very common in orthognathic surgery. I think it's one of the surgeries that uses virtual planning the most, because we're trying to induce aesthetic and functional change in the patient. So in this kind of surgery, we make all the cuts and we made all the movements that have to be planned to the millimeter. And then using patient-specific instruments, we can help transfer that plan from the computer to the OR. Yeah. So in this case, we perform some surgical guides and the splints, which are pretty common for orthognathic surgery. And these tools, these patient-specific instruments, help us to deliver the precise outcomes that we planned in the computer, but in the OR. Now, patient-specific instruments have been, present since the 90s. They have been here for a while, and I like to, show you this study that was done by a German group. And it's named Computer-Assisted Orthopedic Surgery by Means of Individual Templates, Aspects and Analysis of Potential Applications. And this was, done in the 90s, back in 94, like we see in the presentation here. And it's crazy, right? They are being here for so long. So this group was trying to find an alternative to the fully computerized systems. And we all know the computerized systems, like the navigation systems that we can use intraoperatively, which we know they deliver very precise outcomes, but at the expense of having these huge, costly machines and exposing ourselves and the patients to, higher doses of radiation. Yes. So this group was trying to find a simple, and low cost way of implement their planned surgery in the OR. They wanted to eliminate the need of continual radiographic monitoring, radiographic exposure, and all the time-consuming computations. So what they developed was this individual template approach based on the CT, and you can see in this picture on the right the principle of their individual templates, and it's all based on CT scans, and the process is very similar to what we do now with patient-specific instruments. They were molding the shape of a target structure, a bony landmark, and creating individual templates. And what they called individual templates, it's what we now call, patient-specific instruments. And these instruments that they were molding, were being manufactured using milling, which we all know milling. At that time, this seemed like a simpler and lower, cost solution compared to the navigation systems. But however, nowadays we have seen a surge of patient-specific instruments and patient-specific implants, and it's all thanks to 3D printing. 3D printing came to improve the way in which we deliver the solution. Now we know 3D printing is cost effective. There are machines that are not so expensive and they're available to everyone. We have multiple printing technologies going from FDM, SLA, LDP, SLS. We have a variety of materials. We have a variety of materials that we can take into the OR too and are safe to use, for the patients and for us. And that made, easier for us to go from our virtual surgery or plan the computer to the OR. And it made it much simpler and much cheaper. So, I'm going to talk about some case studies. And I think these cases are probably not being talked as much in the conference. So I hope you really find these insightful. And also, this is the best way that I have to explain you how we perform all the virtual surgery and the patient-specific instrument design, and then we take it into the OR to be able to deliver the outcomes that we're interested in. So the first case that I want to talk about is an orthopedic surgery case done by Dr. Felipe in Quito. And it's a case of a patient with a severe synovial chondromatosis. And you can see in the picture on the left, that's the actual anatomy of the patient. That's a 3D representation taken from a CT scan. And we can see there's almost a complete erosion of the glenoid cavity. This patient had severe mobility. He had a lot of pain. And this condition had really impacted his ability to perform daily activities, and work. It has affected his quality of life. So the solution that the surgeon thought for this case was do a bone increased offset reverse shoulder arthroplasty, a BIO-RSA. And here we see some more pictures, so you can better understand the magnitude of the bone defect. So you see there's a complete erosion of the glenoid space. There's no glenoid basically. And this was really impairing these patients, quality of life and daily activities. So what we did here, it's our virtual surgery. So his initial idea was to take a bone graft from the humeral head to fill that cavity and fill that empty space in the glenoid. So we performed the virtual surgery to see whether, his idea was going to work or not. So we went every step, we removed the osteophytes, then we placed that bone graft to fill the cavity, and once we were happy with how it looked, we went on to design the patient-specific instruments, which in this case was a cutting guide to harvest that bone graft from the humeral head. And then this other instrument that would allow us to be able to secure that bone graft in the space of higher bone density in the scapula. So like you see here, we wanted to have a control of how big was the graft that we were going to harvest because we needed to fill that space. And we wanted to have a way to securely place that bone graft into the scapula. And here in the picture on the bottom, you can see this is the space where we wanted to be able to secure that bone graft. Because of the anatomy of this scapula, it was really hard for the surgeon, it would have been really hard for him to determine how to place the bone graft in a place where it's going to remain, rigid and secure. So this was a really important step for the surgery. And without the aid of the PSI, it would not have been able to perform this surgery in one single time. We also, went ahead and thought about the size of the components that we're going to need, the size of the glenosphere base plate, and all of the components for the reverse shoulder arthroplasty. And, this is a really good image. We also 3D printed the models and we practiced on them, to kind of gain more confidence and see whether our ideas were going to, work, have some haptic models that, we can interact with. So this was really nice. And then at the time of the surgery, we had the 3D printed surgical guides. And here's the example of the guide that we used to harvest the bone graft from the humeral head. And then, we had the other 3D printed models so we could, try whether the bone graft was correct or not. And, like you see in the picture in the middle, we have the surgical guide that was going to help us to achieve that precision into securing the bone graft into that scapula. So basically what they did here is they secured that bone graft to the surgical guide, and then they placed the whole surgical guide, into the patient to be able to secure that bone graft in place. And here we have, some images of a post-operative CT scan and, the plan. In the post-operative CT scan, we were not able to achieve the full size and dimension of the bone graft because of the whole metal artifact, of the reverse shoulder prosthesis. But we can see in red here, this line, it's what we planned. This line represents the screw that was going to help fixate that bone graft in a secure place in the scapula. And as you can see, it's really precise. It's almost identical. And it shows how, patient-specific instruments can help us achieve that level of precision that we plan in the computer, but, in the OR. And here's a video of the patient on his second day of physical therapy. And you can see that much range of motion that he has gained just on his second day of physical therapy. Going from not being able to move his arm to having this range of motion, I think it's truly remarkable. And it shows how, with the aid of these patient-specific instruments, we can achieve, great results and improve a patient's quality of life. Now, the next case I want to discuss, it's also an orthopedic surgery case. And I think it's not a surgery that has been discussed a lot within the PSI world. And it's a case of a Lauder J patient-specific instrument done by Dr. Hugo Barros, also in Quito, Ecuador. And here we have a patient, a young patient who's had recurrent episodes of shoulder dislocation. He has had multiple, previous surgeries to repair the instability in both of his shoulder. And however, the recurrent episodes have become a limitation for his daily activities. He was a professional dancer, and he was having a lot of episodes, and it was, being really annoying and painful for him. And it was being, a limitation for, his practice as a dancer. So in this case, the surgeon decided to perform a lateral J surgery with the aid of patient-specific instruments, and I'm going to show you why he decided to go with this approach. And this is a 3D representation of the patient's, scapula with the glenoid space here. And we can see in red, these are some peak anchors from a previous intervention at another institution. And we can see that the location of these anchors is not ideal. We see one of the anchors is embedded in the articular surface, which is not good. So we wanted to decide an instrument that would allow us, to have a very precise lateral J surgery with a high level of precision, and we wanted to avoid, hitting all those peak anchors on the way. We wanted to, have a precise placement of the bone graft flushed with the articular surface, and we wanted to have a precise placement of the screws. And there are currently, the ways in which people do lateral J are different, and they can use, solid regular screws and use a freehand technique. However, the location of the screws might not be the ideal. And then we have, some instruments from a company. I'm not gonna say names here, but we all know that allows us to have a better precision in the screw placement, but at the expense of having to use cannulated screws, which we know they're not, as strong as, regular solid screws. So we wanted to have the best of both worlds. We wanted to have the best and the more precise location of the screws, and we wanted to use solid screws for this technique. So here's a video showing what we did, with the virtual surgery. This approach, we kind of worked it backwards. We took the piece of the coracoid graft, we placed it in, where we wanted to place, and then we traced back the location of those screws to the original position, so we could design, a cutting guide for the coracoid, and then, the patient-specific instrument to be able to drill the holes that would help secure the bone graft in place. So here you have some images, of what the PSI for the coracoid bone graft looked, and the PSI for securing drill the holes that will help secure the bone graft in place in the scapula. So yeah, that was the approach that we took, and here are the outcomes. We wanted to have the bone graft flush with the articular surface in this case. And this picture here, we can see the resemblance, from what we planned to what the actual result in the OR was. And the reason why we made the guide for cutting the coracoid graft, having those drill holes, was because we wanted to have control of where we place the screws, so we prevent the bone graft from fracturing. We want to have the bone graft, be able to be, precisely secured and complete to the scapula. So the results were really good. I hope you can see, the screws are perfectly placed. The precision in placing the screws it's really great. And we also use, regular screws. We didn't have to use the cannulated screws with our surgical guides. So right now the patient is in good condition. He's doing physical therapy. He's reintegrating to his activities. Now I want to go into maxillofacial surgery. I know there has been a lot of talk of this in this conference, so I want to touch into some cases that might have not been discussed as much, and I think are really interesting, and they explain and exemplify well what virtual surgery and patient-specific instruments are. In this case, we have a modern prosthetic-driven approach for zygomatic implants performed by surgeon Fernando Sandoval at his dental clinic. And in this case, we have an edentulous patient with a severe resorbed maxilla, whose current implants got loose. So that had an impact on his quality of life. He couldn't, eat properly, speak properly. So he was a candidate for zygomatic implants. Why we decided to take a prosthetic-driven approach? And I think that's what is very, beautiful and nice about this case. And there's some literature that talks about, why using a workflow, using a prosthetic-driven approach is important. And it's because, palatally positioned zygomatic implants, they can result in a significant bucco-palatal cantilever, speech disturbances, and unhygienic prosthesis contours. So it's really important how we place those zygomatic implants for the prosthesis, okay? Because we want to minimize all the possible complications that come from it, you know. So our idea was to, digitally perform the surgery, place all the zygomatic implants where we want it to be placed in, and then design an instrument, whose goal will be to minimize the prosthetic complications and also increase the accuracy in the implant placement, and at the end reduce the surgical time, help the surgery, make this easier, make these, more simple and accurate. So here are some pictures. You can see the 3D printed model of the patient's maxilla, the 3D printed surgical guides, and here are some pictures of how the surgical guides were used, intraoperatively. The outcomes were really good. They were able to place the zygomatic implants where they wanted, in a short time and an easy way to perform this. But what it's more important than this is, that we were able to have a predictable and precise prosthetic outcome using zygomatic implants with the aid of these patient-specific instruments, and this improves the prosthesis and the implants longevity. You can see in these two pictures the resemblance of how the prosthesis looked in the plan versus how the prosthesis looked, putting the patient after the surgery. So this really, helps to make the work more simple for the person in charge of the prosthesis, and the implant rehab. So I think it's a really good case and exemplifies how, going from a virtual surgery, a prosthetic-driven approach, with the aid of an instrument, we can achieve that level of precision. We also have another case of maxillofacial surgery, and I know you have probably seen a lot of orthognathic surgery. So for this case, I wanted to go with something different, something that might not have been discussed as much. And in this case, performed by Dr. Patricia Unda at the military hospital in Quito, we have a basal extended mentoplasty, which I think is a great case because there was a paper that was just published by a group of Mexican surgeons, and I'm going to talk about it later. But in this case, we have a patient who's orthodontically compensated, However, she's still dissatisfied with the appearance of her face. There's a slight deformity and deviation of the chin compared to the true vertical line of her other, bony structure. And this is the study that I wanted to share with you. This was just published by a group of Mexican surgeons. And in here, they had this basal extended mentoplasty, and the technique they used was, to 3D print the model and elaborate the surgical guide, the patient-specific instrument, using acrylic, and they would use the acrylic on top of this, 3D printed model to design their surgical guide. And, the cut that they designed was a cut that was an osteotomy that was created from the central symphysis part to the basal region of the second mandibular molar, So we wanted to be able to replicate this, but in a more precise and controlled manner. And how did we achieve this? It's all thanks to, virtual surgery and patient-specific instruments. So our goal was to deliver a proper, projection and symmetry of the lower third compared to the rest of the face, avoid any nerve or vascular damage. And in the pictures that you see here, we performed the virtual surgery. We wanted to manipulate, we wanted to make the cut where we wanted in the surgery. We wanted to displace that chin, so we gain more symmetry with the true vertical line. And we wanted to evaluate also how that's going to affect, the patient's, physical appearance. And I think this is really important, to be able to obtain an estimate of what the changes that we're going to induce in the patient are going to look like in the soft tissues. And, once we were happy with this, we went ahead and designed the surgical guide. And here you have the osteotomy plate design. You can see how it goes all the way from here to the base of the second molar region, just like in the literature described that this group of Mexican surgeons says, going from the central symphysis to the basal region of the second mandibular molar. And in this case, we wanted to design an instrument that would be a two-piece surgical guide. And why we wanted a two-piece surgical guide? It was because we wanted to be able to fit through an incision that is not so, big. And we wanted to be able to assemble the surgical guide inside the patient and be able to, deliver that level of precision. So in here you have some pictures of what the two-piece surgical guide looked like, how it was, put inside the patient, assembled, and it helped, perform the cut that we wanted. And the results, speak for themselves. The cut is really precise. It goes, from, this part right here to all the way the back, just how the literature said, from the central symphysis part to the basal region of the second mandibular molar. And the results were really great. We were able to bring back that symmetry to the patient's, face. So lastly, I want to discuss a case of cardiothoracic surgery. This is a case of Dr. Oscar S. Colanquito. And although this case has not been operated yet, I think it's important for me to show you this to also exemplify some other aspects of everything that virtual surgery, and patient-specific instruments can achieve. And in this case, we have a costal cartilage deformity. This patient had a deformity, probably a sequel of a previous trauma to the chest, and it was impacting his quality of life. It was, visually, it was a deformity, and it was also creating mild discomfort when, touching the adjacent structures. So here we have a picture of, what the deformity looks like. And at first, the surgeon just wanted a 3D printed model. He wanted to better understand the size and shape of the deformity, which is not easily, visible in a CT scan. The only parts that are visible are usually just bony structures. And he also wanted to have a better idea of what the muscle volume was in this patient in the left side, where his deformity was. So, we perform a medical image segmentation from a CT scan, and we were able, to put all these, models together that accurately describe, what the muscle volume was and how, what the shape and the size of the cartilage defect was. So we went ahead and 3D printed this, and we delivered this to the surgeon. And after a while, he came back and he was like, I have an idea, and his idea was for the surgery that he would resect all that deformed cartilage, and in place we would, put a patient-specific implant. So in this series of images that you see here, you see, the anatomy of the patient with the defect. Then we just remove that cartilage defect, and we design, a patient-specific implant that would fit right, with the patient-specific anatomy, and would deliver that, a level of symmetry back to the patient. So I'm not gonna go into much detail about what his surgical, technique is, but basically he wanted us, to be able to create a 3D printed PMMA casting mold. So we wanted to have a mold that could be used intraoperatively to cast a PMMA implant. So his surgical technique involves a dynamic fixation of this implant, to the sternum and the ribs to prevent excessive rigidity. But yes, we are gonna design a mold, that we're gonna 3D print it, and this mold is gonna help, cast a custom implant that will be placed in the patient. Now, like I said, this case has not been operated yet. We were planning on having it operated this week so I could present it to you, but we couldn't do it. So once I will have the images, of the outcomes, I'll be happy to share it with you all. I usually share a lot of my stuff and, interesting cases in my LinkedIn profile. If, you can look for me in LinkedIn using this QR code. You can also reach out to me using my email or phone. I'm always happy to discuss cases and happy to share, ideas or share experiences with other people in the field. And with that being said, I want to thank you all for coming. I hope you enjoyed the talk, and I hope this was really insightful for you in, in some way. And thanks, to 3D Graphy for the invitation. It's been a really great pleasure for me. Thank you, you all. I'll be taking any questions. If you want to, just type it in the discuss panel. I'll be happy to answer all of them. Thank you.